Hello, everybody. So I'm just introducing the PHENOX Symposium, which name is Encouraging Clinical Progress, Expanding the Possibilities of Coating. And Laurent PIEROT is going to start presenting coating to optimize aneurysm treatment in the new flow diverter generation. Laurent.
Thank you, everybody. Good morning, good afternoon, I don't know. So in fact, I changed a little bit the title because I was already presenting in great details cutting study last week at ESMINT meeting. So I will focus more on coated flow diverter with preliminary clinical experience we have on cutting study. So my disclosure, I am consultant for PHENOX. So the current status of flow description is following. You know, when we look at the safety, there was a tremendous improvement of safety from the previous study, which was a preliminary study, which was PUFs, showing you see a morbidity of 4.7 and a mortality of 0.9. Moving to a more recent study like SAFE study, which is a study with Fred, showing a morbidity of 2% and a mortality of 1%, or a more recently published the P64 diversion study with a relatively high number of patients, 420, showing a morbidity in 1.5% and mortality in 1%. So at the beginning of our experience with flow diversion, the safety was a little bit less compared to other techniques like standard coiling or standard assisted coiling, but now we see that we have a slow improvement of safety. In parallel to that, we have a very great efficacy of the technique. You see in all studies, when you look at the rate of complete aneurysm occlusion or adequate occlusion, at 6 months or 1 year, you see that the rate of complete occlusion is very high. You see, for example, in PUFs, the rate of complete occlusion was 87%, more or less. And you see that in a more recent study, we still have a very high rate of complete aneurysm occlusion. So what we can say is that safety of the technique is improving and efficacy is probably the highest in the field of interventional neuroradiology for the treatment of intracranial aneurysm. So thanks to this high safety, flow diversion is increasingly used for the endovascular treatment of intracranial aneurysm. At the beginning, it was dedicated to large and giant IC aneurysm and recognized aneurysm. I have to recognize that it's very efficacious for recognized aneurysm. And there is a progressive extension of indication to small IC aneurysm, distal aneurysm, and bifurcation aneurysm. Even if there is still a debate regarding the usefulness of flow diversion in posterior circulation, and also to some extent for bifurcation aneurysm. So the main limitation of flow diversion still is the need of dual antiplatelet therapy to prevent a lot of thromboembolic complications, acute and delayed intrastent thrombosis, perforators and side branch occlusion, distal emboli. So the idea we may have is that to avoid dual antiplatelet therapy, maybe it's a good option to change the surface of the flow diverter in order to reduce platelet aggregation and to be able to work with single antiplatelet treatment. So briefly, what is HPC coating? HPC coating is is a coating that is mimicking glycocalyx. So you know, glycocalyx is inhibiting platelet aggregation on the arterial wall. So PHENOX HPC coating is supposed to modify, to decrease platelet adhesion on the surface of the device which is coated. So this coating was evaluated in several bench tests and animal tests. So I just show you some example here. You see on the left you have the bear device. On the right you have the HPC device. and you know what is in yellow are platelets, and you see that when you use the HPC coating, you have, I don't know if you see yes, you see that we don't have any yellow or very few yellow, which are the platelets. So effectively, HPC, at least in lab test, is effective in decreasing platelet aggregation. Here, another example, you see when it's yellow, you have the platelets. It's a bare device. You have the HPC version. You see not too much yellow. So it means that effectively it is reducing platelet aggregation. Another example at a different level of analysis, you see again it's a bare version, it's a HPC version, and you see that you have a lot of platelets aggregation with a bare and not with HPC. We have had a preliminary clinical experience with both P48 and P64 MW HPC device. I will mostly focus on P48 experience because we have far more patients. You see, we have treated 20 patients with 21 aneurysm. You see that most of them were unruptured or recanalized aneurysm. Because it's a P48 dedicated to a smallest vessel, you know, it was used in bifurcation aneurysm mostly, ECOM, MCA, basilar artery, PCA, PICA. You see the size of the aneurysm, most of them were small, and you see that most of them had a small neck. So in this preliminary experience, we had 3 thromboembolic complications. 2 were intraoperative. In one case, there was thrombus formation in A2 after the placement of P48 in A2-A1 junction. It was treated with tyrofiraban, and there was no clinical worsening. Same for a PICA aneurysm, distal, which was treated with P48 device. There was a thrombosis of the device, treated again with tyrofiraban, and there was no clinical worsening. There was also a post-operative thromboembolic complication in this short series with a migration of the distal part of the P48. It was a left PCA aneurysm treated with P48. Unfortunately, it was not well positioned, so we had to put 2 other P48 to have adequate results, and with 3 P48 in the left PCA, we had an occlusion of the left PCA. It was probably not a good idea to do that, and we had right hemibody paresthesia, which means MRS2. So small complication, but finally morbidity defined as MRS greater than 2 is 0 and mortality was 0. So when we look at DWI lesion, I show you that because we always do post-operative MRI, and it will be part of cutting study. We do that 24 hours after the procedure, and we look at DWI lesions. There was no lesion in 5 patients. There was less than 6 lesions in 31% of patients, more than 6 lesions in 6 patients, and there was a stroke in 2 patients already mentioned. So regarding efficacy, we have 6 months and 12 months follow-up, and you see that again we have a great efficacy of the technique with 81% of complete occlusion at 6 months. The population is not the same at 12 months. We have only 15 patients with a follow-up. The reason why we have only 73% of complete aneurysm occlusion, but still we have a high rate of complete aneurysm occlusion. Just to show you an example here. Ruptured ECOM aneurysm treated in 2010 with coils with a good anatomical result at the beginning. 2019 recurrence. The strategy is to put additional coil and to avoid recurrence to put P48 in the left A1, A2 junction. So it was done. You see the additional coils here and the flow diverter in the, sorry, but I have a problem with the mouse, but you see the coils on the flow diverter, and it's 24-hour MRI, and you see that we have some spots in the MCA territory. and it's a DSA at 6 months, 12 months showing complete aneurysm occlusion. So now what is cutting studies? You know, we have a surface modification of the P48, P64, and what we want to know if we can reduce antiplatelet medication. So for that we have decided to conduct a European multicenter prospective randomized controlled trial, which will compare aneurysm treatment with a bare flow diverter, P64, P48, MW, under dual antiplatelet treatment, which is the usual regimen, to the treatment with a coated P64 or P48 MW HPC using single antiplatelet treatment. So the study design is, you understand that we will compare HPC coated flow diverter with single antiplatelet treatment to bare flow diverter with dual antiplatelet treatment in patients with unruptured, unrecanalized aneurysm. So the primary hypothesis is that the coated flow diverter with single antiplatelet therapy is non-inferior to bare flow diverter plus dual antiplatelet treatment. The secondary hypothesis is that it is superior. So we have an adaptive design of the study which permits us to move from non-inferior to superiority according to intermediate analysis. The primary endpoint will be the number of diffusion-weighted imaging lesions assessed within 48 hours of the index procedure with MRI and DWI. So we have a lot of secondary endpoints, very classical: morbid mortality, neurological death or major stroke at 6 months, 1 year, complete morbidity evaluated with MRS, mortality indeed. We have also a point regarding the number of diffusion-weighted imaging spots. Indeed, we will evaluate the hemorrhagic complication, intracranial hemorrhage from delayed aneurysm rupture or from delayed remote hematoma. We will also evaluate some points regarding to efficacy, which are successful device development, complete aneurysm occlusion, target aneurysm recurrent, retreatment, intrasplenic thrombosis or stenosis, length of hospital stay. So the goal is to include 200 patients max with 25 centers in Europe. So here are the timelines of the study. So the first patient in was supposed to be Q3 2021, and by chance we were enrolling the first patient in my department, and we will treat this patient next week. So I will not go through the inclusion-exclusion criteria because they are very usual. You know, we have a specific point, which is that we can include ruptured intracranial aneurysm as long as they have the rupture occurred more than 30 days ago. Otherwise, all inclusion criteria are usual. We want to have only one target aneurysm, except for a specific situation, which is segmental disease, when you have several aneurysms on the same segment. We have also a lot of exclusion criteria: previous recent surgery, recent intracranial hemorrhage or subarachnoid hemorrhage, if the target aneurysm was previously treated with stent or flow diverter, indeed, if there is a confirmed stenosis in the parent artery, also if there is some atypical form of aneurysm, blister-like fusiform dissecting associated with an arteriovenous malformation, and also if there was a stenting of the ipsilateral carotid artery within 3 months, is non-inclusion criteria. On other usual factors like contraindication or allergy to heparin and other antiplatelet drugs. So the randomization process will be very classical. It will be 1.1 randomization with the EDC. You know, if the randomization can be P64, P48 HPC with a single antiplatelet treatment, or the Bayer flow diverter with dual antiplatelet treatment. So all will be under routine care. There will be SAPT until 6 months post-procedure for the Bayer arm. And so the treatment will be ticagrelor or prasugrel. And after 6 months, we will stop ticagrelor or prasugrel and continue with aspirin for at least 6 months. And in the dual antiplatelet treatment group, or HPC group, we will have, the Bayer group, sorry, we will have dual antiplatelet treatment for 6 months with ticagrelor or prasugrel and aspirin, and after 6 months we will stop prasugrel and ticagrelor and continue with aspirin. So we have a lot of committees for this study, which is normal. So the steering committee, is me, Chris, Laurent Spell, and Salamine. We have also some committee for the follow-up of the study. So the DMC is Professor Filler, Dissal, and Kakerini in US, who is a statistician. For the CEC, for the adverse event, we have Professor Roto, Sotaris, and Fischer, who is a neurologist, vascular neurologist, and we have an imaging collab with Professor Clarençon on Engelholm in Germany. In conclusion, flow diversion is clearly one of the major endovascular treatments for the management of intracranial aneurysm, singularly unruptured and recanalized as of now, thanks to its high efficacy. Surface modification of the flow diverter will potentially decrease platelet aggregation and thromboembolic events and permit to use SAPT, and it will potentially permit its another step, the treatment of ruptured aneurysm. So cutting study, to my best knowledge, is the first multicenter RCT comparing bare flow diverter plus dual antiplatelet treatment against coated flow diverter plus single antiplatelet treatment. Thank you for your attention.
So thank you, Laurent. Do we have any question about the coating study from the audience? Yeah. On va avoir un microphone, s'il vous plaît. So again, it's the first time there is a randomized trial with single antiplatelet and a new generation of flow diverter.
This is Mohammed Al-Mahdi from Egypt. I want to ask why it was chosen the ticagrelor or the prasugrel instead of aspirin in the single antiplatelet arm.
Excuse me, I misunderstood the question.
You didn't use aspirin as single antiplatelet drug. So is there a reason behind this?
That's a very good point. You're right. The goal is not to have a coated flow diverter with prasugrel or ticagrelor, but with aspirin. But the preliminary experience with coated flow diverter, including Medtronic pipeline shield and including P64 HPC, is that with aspirin we are not completely sure that it will work. So as a first step, we were using a more potent antiplatelet medication to see if effectively we can move from a dual antiplatelet medication to a single antiplatelet medication. But I agree with you that the goal finally is probably to have a single antiplatelet treatment with aspirin. But we go step by step, which is in my mind the right way to go.
Some other question?
Laurent?
Yeah, sorry.
Is there already in the literature a study comparing aspirin alone and ticagrelor or prasugrel alone?
No.
Okay, so how will you manage the second step?
I will manage first the first step.
You manage
I will think about this. No, but let's say it will depend on the results. I am quite confident that at least we will have non-inferiority, and it's not a goal to have superiority in my mind, but that's true. So thereafter, The problem will be effectively to compare single antiplatelet therapy with a more potent drug and a less potent drug, which is aspirin. So it will be a next step, but we will see, according to the results we have with this first study, which is cutting. But I agree that I think to that, and we have to find a solution to evaluate single antiplatelet therapy at one moment with aspirin.
Okay, no other question? Okay, so we are going to move to a talk from Markus HOLTMANNSPÖTTER about Pegasus HPC, first clinical experience with a new coated intracranial stent. Welcome, Markus.
Thank you, Christophe, for the nice introduction, and thank you, Jacques and Laurent, for giving me the opportunity to speak here. It's really the first for me, and I don't have a series yet of cases, and these were my disclosures. I'm talking about the Pegasus HPC stent system, which is a self-expanding open cell stent design, which we know also from other companies, but this stent does have a HPC coating, which is new beside the coating available on flow diverter stents. The vessel size is given from the company from 2.5 to 4.5 millimeters, and you can put it through any 17 or 16.5 microcatheter. I have my experience in the incidental icoterminous and MCA bifurcation aneurysm in the 60-year-old woman. This was an incidental finding on a workup, as she has an extended history of malignomas, including mammary and pulmonary cancer, about 5 and 10 years ago, but she, at the point of the diagnosis, there was no signs of recurrency or any malignancy, so expected normal life expectancy. She has an additional cardiac condition with the need for permanent anticoagulation with rivaroxaban, a factor XA, a 10A inhibitor. So the issue is then, if you do stent remodeling, do you need to put the patient on a triple antithrombotic therapy, which is known to have a higher bleeding risk, and not surprisingly. In cardiology, antithrombotic therapies with 2 medications have been proven effective, but we don't have sufficient data yet. So in her situation, I thought it's a very good idea to have a coated stent to do stent-assisted treatment of her 2 aneurysms. And I won't go over the coating. Laurent just explained that. Here, another image of the stent. So you can see it's an open cell stent with slightly flared ends. Now this or other way around. The official indication is for aneurysm remodeling treatment, for intracranial artery stenosis, or treatment of dissections. The given vessel size from 2.5 to 4.5 millimeter covers most of the range, though I wouldn't be hesitant to put this stent also in a smaller vessel than 2.5 millimeters. I did it often with the Atlas stent, for example. To treat the patient, I loaded her only with ticagrelor 5 dyes. Prior to treatment, continued her rivaroxaban, and no aspirin was given. And the treatment was planned only with HPC-coated stents and coiling. Additionally, she has a very tortured aortic arch and elongated vessels. Here in the axial plane, you can see here the carotid, the common carotid emerging from there. For this reason, I decided to do a transradial approach. This you can see here. This was very uneventful. This is a ballast sheet from BALT and followed by an Embovac catheter. I choose the Embovac because of the large bore size, the 071, which I thought is suitable for 2 microcatheters without too much friction, but also to have enough distal support. Here, that's initial DSA of the 2 aneurysms. So especially the ICA aneurysm popped up for getting the indication for treatment, but also the MCA aneurysm doesn't look very, very good. You see better projections in later images. The ICA aneurysm is more than 1 centimeter. We treated that with a P64 HPC stent, uneventful, and then focused on the treatment of the very wide-necked trifurcation aneurysm and the MCA. The access was done with 2 headway dual catheters and a Shikai 14. And if you go from left to right, you see here canalization of the easiest straightforward going branch, passing this third branch, which there is no stent coming in, but we thought the stent will cover that origin sufficiently. And after placing that stent, you see here the red circles or orange circles, they are the distal and proximal markers of the Pegasus stent. Then through the stent, the second branch, which was more difficult to reach, was targeted. And finally, I was sufficient, not with the Asahi Shikai 14 in the first place, but had to use a 007 hybrid microwire with a J-tip, but then I could get distally and place a headway duo. I had to get the embovac higher up. Something is getting automatically in the other direction, so don't know. This slide, yeah. So, and the second stent is placed here. Due to the nitinol character, so the visibility is reduced, and I don't have the most modern angio suite at the moment. But on 3D, you can get an idea that the stent is nicely opened. Here on the fluoro image, you can see the shadows of the struts, so I was very confident that we have a nice opening. I jailed the first microcatheter between the second microcatheter stent into the aneurysm and placed 4 hydrocoils. In the end, I ended up with a pretty loose coiling, as the last coils always tried to move in front of the third branching vessel, and I thought it's an elective case, and with this Y stenting and hydrocoils, I have sufficiently treated that MCA aneurysm, and also the carotid aneurysm shows some early contrast retention. The patient was discharged without any neurological deficits, continued on ticagrelor and rivaroxaban only. Unexpectedly, she presented 6 weeks later, just the last week, with vaginal bleeding, and the diagnostic workup revealed now a cervix cancer, a consequence of which the patient was hysterectomized, got a complication with a rectum perforation, and got further surgery. Unfortunately, I don't have follow-up images, but I've seen the patient. She's in astonishingly good humor, and so far the message is that the treatment with the Pegasus stent in Y fashion is feasible and possible, and the coating with the HPC gave me confidence to have her sufficiently platelet inhibited with rivaroxaban and ticagrelor only. And I assume, so as she doesn't have, even with their dire situations, any neurological symptoms, that the treatment was successful. The stent performance was, the pushability and deliverability was very easy due to the nature of the stent nitinol. The visibility is reduced, but sufficient, especially probably if you have a more modern angio suite. And I think that's a good option in difficult situation with concomitant diseases, and I'm looking forward to get more experience with the HPC coding in normal stent and remodeling cases. Thank you.
Thank you, Markus. Any question, comment about the coated stent?
Christophe, just before you answer the question, I called the panelists for the next session. Marc Ribot, René Chapeau, Mayank Golal, Monica Killer, Daily Mail, please, and then we can answer the question.
No questions about the coated stent? Okay. Markus, I don't know at all, but I know that in the flow diverter, the P64, P48 HPC, there is something said in the IFU that allows you to use the stent in the acute phase of a rupture with only one antiplatelet. Is it true as well for the stent?
Yes.
Okay, so does it change your practice, the fact that there is a HPC coating on the stent? Do you use it more often in ruptured cases? Or do you change your regimen and use only aspirin, for example?
I feel more relaxed. I used stents, flow diverters, also the pipeline shield already in the setting of single antiplatelets if I use treat a blister aneurysm. But if I have a kind of like official statement, it feels better. Okay, you can do it, but they don't advocate it. But they say in dire situations, you can do a single antiplatelet. So they don't advocate just to use it only. Yeah?
So will there be a registry, at least on the cases done under only one antiplatelet, to have information about those cases later on?
Not yet, to my knowledge, but I think that's desirable. I think Laurent PIEROT's study regarding that coding is the first real randomized trial, and I think a registry is desirable that we get prospective data, so just not single
cases.
Because
the HPC seems less useful on the stent than on a flow diverter because there is less metal, but it may change completely the way we use stent, and indeed in the acute phase of a rupture, we could use it more and more compared with what
I think so.
Okay, no other comment, no. And Jacques, do you know if we can have the...
No, I have a comment. The faculty, somebody maybe can answer the question. We started with self-expandable stent, balloon self-expandable stent from the cardiology. Then we have the self-expandable laser cut, Neuroform Easy or Neuroform and Enterprise. And then we got the braided stent, and now we are back to the laser cut stent. Why?
Thrombogenicity.
Why?
They seem to be more thrombogenic. Braided are more thrombogenic than the laser cut. More material.
And they seem or they are?
Those studies as well as I do.
Yeah. Do you think a white stenting with a laser cut stent is less thrombogenic than a single flow diverter, for example?
Depends on the anti-aggregation.
Okay. I think we have the question, the answer. Okay, so can we get an answer from the question in the on the screen? Who is ready to participate to a study? Flow diverter aspirin alone and flow diverter double antiplatelets.
As an operator or as a patient?
No, as the patient, the answer is no. So because we prefer the operator. So. Okay, so maybe we'll get the... we already have it? Yes, 53%. Oh, it's not bad. So next time we'll do that with the patient and we will see if it's different.